Good morning. Today we're going to be talking about endocrine scintigraphy. This encompasses thyroid, parathyroid, MIBG, and somatostatin receptor imaging. Thyroid scintigraphy, this is the most common and often the most challenging part for our trainees. So how can you come into contact with one of these tests? In reality, there are only two appropriate indications. Number one is abnormal thyroid function test, which should be followed by thyroid scintigraphy and not thyroid ultrasound. The second is thyroid cancer therapy and follow-up. These are much less common than abnormal TFTs. Indications such as palpable nodule, incidental thyroid nodule, decisions to biopsy or not to biopsy, and thyroid nodule follow-up are not appropriate uses of nuclear medicine thyroid scintigraphy. Thyroid function, this is actually somewhat complicated to interpret, although for our purposes the key question is TSH up or down, is T3, T4 up or down. There are a lot of intricacies, so whenever I hear subclinical hypothyroidism from anybody other than endocrinologist, I try to tear my hair out, and if you've seen me, you understand this is actually what happened to the hair. So this is the typical clinical pathway. Endocrinologist tells you low TSH, high T3, and what is the clinical differential diagnosis, and what is the next step. And as we just talked about, the next step is I-123 thyroid scintigraphy, and we're trying to distinguish these three clinical scenarios. So I'm going to give you 3 seconds to correctly name each one. All right, I'm sure all of you got this right, and the image on the left side of the screen is thyroiditis. So we see absolutely nothing, no uptake, and this is when thyroid inflammation causes spillage of thyroid hormones. So we're going to have an oversupply, and that's going to be transient. So if you see this, the endocrinologist just needs to wait out. Image in the middle is Graves' disease. We see elevated 24-hour radioiodine uptake of 66%. This is extremely characteristic, nothing else that can do this. So we see this, we can confidently diagnose Graves' disease. The image on the right is autonomous nodule, and this tends to be misunderstood. You can have a single autonomous nodule, you can have multiple autonomous nodules, it doesn't really matter. This is essentially a nodule that will keep producing thyroid hormones despite low TSH and the body telling it to stop. Usually the severity of hyperthyroidism is not going to be as bad as in Graves' disease, but nonetheless images are pretty telling. So really we're looking at one of these 3 scenarios, and it should be pretty straightforward. The 2 radiopharmaceuticals that we should be using for thyroid scintigraphy are I-123, which is the mainstay. It's physiologic, easy to use. Challenges, somewhat higher cost, maybe less convenient, not quite as available as TEG, but nonetheless availability is pretty routine. In certain circumstances, we can use technetium-99m pertechnetate. Most often, this is actually used when patients just got iodinated contrast, and the thought is we should use that to avoid competing with the iodine. It tends to be case-by-case selective. I'm honestly really not sure that we really should use it. I think I-123 would give us an answer in almost every situation. Theoretically, I-131 used to be used in really small doses, but its use should be absolutely discouraged. That's, in the modern age, would be barbaric. Adult dosimetry, these are the numbers. In theory, you could be tested in them, but honestly, probably not. All right, so in nuclear medicine, we always have to deal with patient preparation, and when it comes to thyroid imaging, we have to deal with issues of pregnancy, iodinated IV contrast, anti-thyroid medication, so methimazole and PTU, and the questions of low iodine diet. Actually, that low iodine diet is pretty painful. Wouldn't recommend it for anyone. So number 1, in all nuclear medicine tests, we must exclude pregnancy. So we need to have a negative pregnancy test. When it comes to anti-thyroid meds, all we really need the patient to stop them is for 2 to 4 days. Some departments require a week, 2 weeks, a month. This is excessive. So For methimazole PTU, we only need the patient to stop them for 2 to 4 days. 2 days is really sufficient. If the patient is on Synthroid, so that's T4, they need to stop the medicine for 4 to 6 weeks. It's pretty long acting, so it takes that long for it to wear out. If the patient is on Cytomel, that's T3, we need to have the patient stop it for 2 weeks. So it's not an uncommon strategy if interruption of therapy is problematic to switch the patients from Synthroid to Cytomel, and that allows much shorter interruption. If the patient has had IV contrast for CAT scan, we shouldn't do this realistically for about 4 weeks. In theory, 2 weeks may be sufficient, but I personally prefer to wait 4 weeks. If the patient has had amiodarone, the effects may persist for 6 months or longer. I have seen cases where the effects persisted for several years. Amiodarone tends to get stored in the liver, so it's available to compete with our I-123 for quite a while. Low iodine diet for 7 to 14 days is only useful when we're treating patients with thyroid cancer, and especially the more aggressive or high-risk area disease, just so that we're trying to optimize every single variable, so we'll deprive the body and the tumor of dietary source of iodine, so that way the iodine that we're giving the patient is more likely to get taken up. Meals can interfere with iodine absorption, so when we give patients I-123 or I-131 therapy, we tell them usually to avoid any food for at least an hour so that the iodine can get absorbed. Drinking is fine. Typical doses for I-123, it's a fraction of a millicurie. For technetium, it's about 10 millicuries. Collimators, on the heels of the general nuclear medicine introduction lecture, thyroid is a superficial structure, so we should be using a pinhole collimator on the gamma camera. Parallel hole collimator is sufficient for thyroid imaging just because we're not looking to resolve tiny structures, but pinhole is generally preferred. The process is radiotracer is given orally, and imaging is started for 24-hour radio and an uptake 24 hours later. If we're using technetium, then we can image 10 minutes afterwards. Generally, patients should be laying down with the neck hyperextended, and we will acquire anterior with a marker, and then both oblique views, typically using counts or imaging time for 10 minutes. Either way is sufficient. So you can see it takes about roughly 30 to 40 minutes to perform this test. Thyroid uptake, normal range is said to be 10 to 35% for 24 hours. The 4-hour values are 6 to 18%, but they're not as robustly established. Furthermore, even the 10 to 35% range is based on literature from 1960s, 70s, so this is outdated. Nowadays, we have a lot more iodine in the diet. Most of it comes from iodinated salt. However, a lot of it comes from the dairy, because when the cows are milked, the cow udders are wiped with betadine, so that serves as a source of iodine as it seeps into the milk and all of the milk products. So don't get obsessed with numbers. I have seen Graves' disease with uptake of 80%. I have seen Graves' disease with uptake of 30% because the patient has a lot of dietary iodine. So it's important not to be stuck on exactly on the number and to assess it in the context of the patient's disease and how the imaging looks like. Again, going back to these pictures, it's pretty straightforward. In thyroiditis, you're going to see no uptake. In Graves' disease, the uptake is going to be uniform and generally very increased. If the patient eats a lot of salt and dairy, they can suppress the uptake by giving the competing dietary iodine, but again, the uptake will be homogeneous. In autonomous nodules, you will see a nodule that's hotter. You may have multiple autonomous nodules in settings of multinodular goiter, but again, this is usually pretty easy to tell from a homogeneous uptake of Graves' disease or no uptake in thyroiditis. All right, so we're going to switch gears. We're going to talk about hyperparathyroidism. Uh, this is when we function to help our clinicians in identifying the nodules to enable the surgeon to perform the most minimally invasive surgery. And there is a large number of techniques. When I was a medical student, I remember being in the operating room with Norm Thompson, who was the father of parathyroid surgery in the United States, and the standard of care was to fillet the entire neck, identify all of the four glands, and then take them out with immediate intra-op testing to make sure that the levels of PTH have dropped. These days, there's a huge drive towards minimally invasive surgery, so our goal is to identify the location of the abnormal parathyroid gland so the surgeon can target it with a small incision, laparoscopic incision, or these days in certain centers there is an advanced surgery. For example, the surgeon will go transorally tunnel underneath the skin and then will be able to get to the parathyroid gland. So to do this correctly, the surgeon needs to know exactly where the abnormal parathyroid adenoma is located. And this is where we come in. The range of tests include nuclear medicine system IBI scans, ultrasounds, multi-phase CTs, and MRs in theory, although MR has not proven to be super helpful. And these days, primarily the surgeons rely on nuclear medicine tests as well as on multi-phase CAT scans, frequently known as 4DCT. So I'm sure this diagram represents a long forgotten cycle for everybody, and honestly, I don't remember it that well myself. So all I know, high PTH, increased serum calcium, and this is based on signaling within the bone, gastrointestinal system, and the kidneys. Normal parathyroid gland is really, really small. I remember the amount of trouble it would take a surgeon to find a normal gland. It's much easier to find an abnormal, so really, really tiny. There are four glands, two superior glands and two inferior glands. Occasionally, some patients will have more, some patients will have less, which makes it kind of fun for the surgeon, but most typically two superior and two inferior glands. Superior gland is located deeper. It's located in a tracheoesophageal groove. It's usually behind the upper or mid pole of the thyroid gland. So anatomically, if we see something lighting up in the region of mid to upper pole, it's usually a superior gland. If we have a SPECT CT, we can make sure we can localize it into the tracheoesophageal groove. Inferior gland embryologically come from the same tissue as thymus, so it's usually located between the inferior pole and the thymus itself, so it tends to be a much more superficial structure. It does matter to the surgeon whether they're going after the inferior or superior gland because they expect to find it behind different layers of fascia. So again, inferior gland is going to be much, much more superficial. Again, because of its embryology associated with thymus, it could occur anywhere from its expected location to the mediastinum, so this is much more likely to become ectopic. Superior gland, as it gets bigger, may descend and may drop down as well. So these are the most typical locations for both superior and inferior glands. Again, superior gland, tracheoesophageal groove. It is along the tracheoesophageal groove. The bigger it gets, the lower down it will be found. The inferior gland is much, much more superficial and tends to be most often located between the inferior portion of the thyroid gland and the thymus. So there are many types of hyperparathyroidisms. It gets really, really complicated, and you can start adding a prefix of pseudo, pseudo, pseudo when I quickly get out of my depth. What we are generally looking for is primary hyperparathyroidism. So we're looking for elevated calcium level, we're looking for elevated PTH level, and this is a disease that's surgically curable. Secondary and tertiary is usually not a surgical problem, so this is not what we're going to be looking at. Parathyroid carcinoma is usually very, very rare, and it's very hard to identify on pre-op imaging, although there are certain indicators such as big size, ill-defined margins, something that looks invasive, but surgeon will frequently discover that the lesion is a parathyroid carcinoma because they're having a hard time removing it. Benign adenoma is usually very, very easy to remove. So this is primary hyperparathyroidism, and we're seeing a system scan where on the initial 15-minute images, we're seeing uptake by both the thyroid gland and parathyroid adenoma. The parathyroid adenoma is a little bit hotter than the gland, but still discernible. On the delayed images, at 2 hours, we can see that the thyroid gland has mostly washed out, whereas parathyroid adenoma is hanging on to the sestamibi. And this is the most typical behavior. Now, we see the uptake to be located in the region of the lower pole, so this becomes difficult to differentiate. Is this the superior gland that's descended down, or is this the inferior gland that's more superficial? And if we look at the ultrasound image, we can see that the nodule is behind the thyroid in a tracheoesophageal groove, so this is a descended superior gland. Ultimately, I do find combination of functional testing with sestamibi and some sort of anatomic imaging with either ultrasound or CT to be superior, because we can localize the lesion and can make sure that anatomically it's where we tell the surgeon it is, just to make the surgery faster and easier. This is another example of hyperparathyroidism, which in this case caused by four-gland hyperplasia, which was really difficult to find. We actually used an ultrasound scan to locate every single one of them, and it was quite a painful ultrasound scan, but we did identify them all for the surgeon. Again, this is another example of parathyroid adenoma. You can see that even in initial images, all we really see is a parathyroid adenoma, barely any thyroid uptake. And in the delayed images, again, the uptake persists. Ultrasound, again, demonstrates a hypoechoic perivascular nodule, and we were able to localize it for the surgeon. There are a lot of important factors that go into management of hyperparathyroidism that it's not really important to go through. This will typically be performed by endocrinologist, the endocrine surgeon or ENT surgeon who's operating. By the time they get to the surgical criteria, then the surgeon will send them to us to localize an adenoma prior to surgery. It's just to make surgery easier and faster. There are obviously many pros and cons. Surgery is quick and cures, but again, in many patients, there is not enough of a disease severity or progression to truly justify surgery and the risk of anesthesia. Surgical techniques have evolved over the years from extensive neck explorations to minimal invasive surgeries with the small incisions, laparoscopy, or distal tunneling in the perpetual quest to avoid any scars. There is some work that has been done on ethanol injection into the adenomas, and it seems to be successful with potential to avoid surgery and achieve a rapid cure, but at this point this is still highly experimental. There is some data on using intraoperative radio guidance similar to axillary dissection in breast cancer. This largely came from one of the surgeons in a large center in Florida where they inject sestamibi and use an intraoperative probe. This has not become very widely adopted. Intraoperative PTH monitoring is essential to make sure that the correct lesion has been resected, and if the correct adenoma has been resected, the PTH should drop rapidly, enabling intraoperative confirmation, and if not, then the surgeon will search for additional lesions. We talked about pre-surgical localization tools. Currently, most surgeons and most institutions will use sestamibi. Scintigraphy with SPECT-CT when available, plus ultrasound. However, increasingly CT is replacing system maybe because it's just easier and more reliable, and everybody understands the anatomy on CT so much better. The mechanism is localization of adenomas is avid mitochondrial uptake of system maybe, and typically parathyroid adenomas tend to hang on for it much longer than the thyroid gland. So this is an example of slightly ectopic gland, and we can see that these are the images that were acquired with cardiac SPECT. We can see the heart avidly taking up system AB as well as the parathyroid adenoma, and images on the right is the dedicated study that was performed to detect the parathyroid adenoma. So anytime you're reading nuclear medicine stress test, look at the non-processed image. You may be able to find a parathyroid adenoma or breast cancer or something else that tends to hang on to system AB. This is a typical images for a SPECT that presumably, again, should solve the problem. Is it whether it's a superior or inferior gland by providing accurate anatomical localization. In my prior experience, it doesn't seem to be a solution due to really poor quality of the CT images of a typical SPECT CT. However, the technology is not staying still, and I'm sure the latest generation of these studies improves the localization. Again, this is an example where a SPECT CT was able to localize an intrathyroidal parathyroid adenoma, which would be extremely challenging for a typical system AB scan without the SPECT CT or with CT. Only with the combination of a CT and SPECT, we're able to say, okay, we have a system AB uptake in the middle of the thyroid gland. This would be very, very difficult for a surgeon to identify without using preoperative guidance. And this is, again, another example of using fusion images to localize. This is an example of mediastinal location for parathyroid adenoma. This situation is challenging regardless of an imaging modality used. Obviously, not a possibility with ultrasound. Even with CT, would be really, really hard to guess. System AB is pretty much the only thing that will suggest abnormal ectopic location like this in combination with SPECT CT, making it much easier. So again, other examples. One of the common pitfalls is salivary excretion, and we can see some uptake below the thyroid at the top row of the images and on the right, and this is easily callable. However, this is actually just a salivary excretion that can be identified by looking at all of the images. And again, as you can see, some uptake along the esophagus that clears after administration of water. Parathyroid adenoma with ultrasound localization, pretty good, but it requires somebody that knows what they're doing. A usual thyroid ultrasound is not going to identify, so we want a competent technologist or competent sonographer who knows where to look. We used to have an endocrine surgeon that practiced at FITS that retired, and he generally liked us to do a combination of both system AB and an ultrasound. Typically, we would actually start with system AB, and from nuclear medicine department, after the initial images, we would send the patient to ultrasound, attempt to localize the suspected location, and then send them back to nuclear medicine to confirm. So I find ultrasound and system AB scans to be pretty additive, and they tend to work very well together. Again, this is another example of parathyroid adenoma localized in both ultrasound and system AB scan. This is an example of a lesion that's localized on CT and a sestamibi scan. You can see in this particular case, because of asymmetric salivary gland uptake, it's really, really easy to get confused and make up an ectopic parathyroid adenoma and sestamibi. But on CT scan, we can easily see that it's a normal salivary gland, and there is actually a lesion right below the thyroid that's a parathyroid adenoma. This is another example where we actually used all three modalities to localize combination of CT, sestamibi, and an ultrasound. Given choice, I would do this every single time, but somehow that doesn't seem to fly. Usually we get a combination of the two. This is sestamibi on the PET CT. This is an FDG, increased FDG uptake. As we talked, we use sestamibi because of parathyroid adenomas having lots of mitochondria, and this is the same tissue that will localize pretty well with FDG. So theoretically, this would be a great test to localize parathyroid adenomas, but somehow insurance companies in the United States never pay for it, although it would probably save money in the long term. Another example of a lesion that we're localizing on an ultrasound and sestamibi scan. This is an ectopic lesion. We are seeing it on the image on the right on the parathyroid scan, and subsequently able to find it in both CT and MRI, again enabling surgical intervention. Sometimes the surgeons tell me if it's not too low, they would just cut behind the sternal notch and would start pulling on the thymic tissue, hoping to pull out the parathyroid adenoma along with the thymic tissue. Nowadays, with improvements in endoscopic techniques, something like that would not be necessary. The biggest challenge for localizing parathyroid adenomas, if we see something, tends to be ectopic thyroid tissue in the mediastinum, and sometimes it can extend, sometimes we can have a separate mediastinal goiter, and it takes some experience and some effort in telling this apart from parathyroid adenomas. One modality that I do find helpful for that is actually non-contrast CT, because thyroid tissue is normally bright, whereas a parathyroid adenoma is not going to be bright because it does not have iodine, so that can make all the difference in the world. Again, it's easy to confuse just a simple simple thyroid nodule with a parathyroid lesion. And on the CT here, we're seeing something that's not as dense behind the gland, but if we look at the corresponding ultrasound image, it's just a simple cyst. Lymph nodes sometimes could be really tough to tell. This is a really excellent paper in Radiology that was published in 2015. They talked about the different patterns of parathyroid gland enhancement on CT. And sometimes the parathyroid will enhance more than the thyroid, sometimes it will enhance the same way. Sometimes it will wash out more, sometimes not. But the uniform feature of all of the parathyroid adenomas is that they tended to be less dense than the thyroid gland in the non-contrast CT. And this really helps to localize them. Sometimes not easy because it's difficult to tell from a regular lymph nodes. I'm sure with our current dual energy CT, this would become even easier, although I don't really have a lot of experience on dual energy CT with this type of lesions. Again, many centers, multi-phase CT has replaced sestamibi and ultrasound. And this is a table from the paper. I'd encourage everybody to look at it. Okay, now we're going to switch gears to talk about MIBG. This is something that has been around for a while. It works really, really well. It's used to image tumors of neuroendocrine origin, so particularly pheochromocytomas, paragangliomas, and neuroblastomas. However, other neuroendocrine tumors such as carcinoid and medullary thyroid cancer will also pick it up. Um, MIBG theoretically can also be used to image sympathetic innervation, but this is not done outside of the research. So essentially, it's a precursor uh, that's used by these neuroendocrine cells. So if we see uptake in a tumor, it tends to be pretty specific. MIBG can be labeled with both I-131 and I-123. Obviously, I-123 is the preferred labeling agent in the modern world, although in the past I-131 was not that uncommon. And I-123 is obviously better for imaging just because of the energy of the gamma particle that it emits, just makes it much more friendly, as well as has much less radiation. In general, when imaging cystamebi, we want to block normal thyroid gland to prevent iodine from going into it. So this is a simple protocol that is used in most radiology departments to image the gland. Pregnancy is a contraindication, but certainly if we're worried about pheochromocytoma and paraganglioma, there's a variety of factors that can come into play. For breastfeeding, for I-123, breastfeeding should be stopped for 24 hours. For I-131, breastfeeding should be stopped, but these days I can't imagine anyone using I-131 MIBG on a pregnant patient. Imaging with I-131 can be done for many days after the injection because of its long half-life. With I-123, it's typically performed a day later, so it's 24 hours than the injection. Occasionally, we will do delay, but typically a day after the injection, the answer is pretty clear. Normal uptake can occur to variable degree in nasal mucosa, lungs, gallbladder, colon, and uterus. There can be some uptake in the digestive system as well as the thyroid if the thyroid gland was not properly blocked. So this is a typical distribution of I-123 MIBG. We can see some uptake in the right adrenal pheochromocytoma, as well as a little bit of uptake in the liver, as well as the bladder and the salivary glands. This is another MIBG scan. We can see that there's a paraganglioma. It's located inferior to the renal veins. Actually, this is the most common location for paragangliomas. It's not the organ of Zuckerkandl, as written in many books and articles. It's actually in the largest studies. It's the paragangliomas tended to be most often found inferior to the renal veins, and we can see really nice localization. Certainly here we did not do a great job of blocking the thyroid because it's showing up as well. This is another example where we can see paraganglioma just below left kidney, and we can see very characteristic imaging pattern of marked enhancement. We can see intermediate to high T2 signal with flow voids and the lesion indicating its marked vascularity, but on MRI the appearance is highly suggestive. The increased MIBG uptake in the lesion is diagnostic, so we can confidently diagnose this as paraganglioma. There's a variety of sources of error that can occur in MIBG scan. However, in my experience, this is usually not an issue unless the tumor just refuses to take MIBG, and that certainly happens. Tumor can do whatever tumor wants, which is why cancer imaging is fun or interesting. But if the tumor does take it up, the diagnosis becomes very, very clear. All right, let's switch gears and go on to the fourth part of today's lecture, to somatostatin receptor scintigraphy. And this relies on detection of somatostatin receptors on neuroendocrine tumors. And there's a variety of molecules that are targeting agents that have significantly improved over the last few years. The original molecule was octreotide targeting agent that was typically labeled with indium 111. The tumors that have high expression of somatostatin receptors include adrenal medullary tumors, so pheochromocytomas, neuroblastoma, ganglioneuroma, and paraganglioma.